Hello, good evening, everyone. Thank you so much for joining us this evening. This is GUTS in the virtual community. And for those of you who are joining us for the first time, GUTS stands for Georgetown Howard University's Center for Clinical and Translational Science. And this month we are presenting on breast cancer, as it is Breast Cancer Awareness Month. And we will specifically be talking about breast cancer screening, quality of life, and health equity. We are also honoring the life of Henrietta Lacks and her contribution to cancer research. And our moderator tonight is Florencia Gonzalez, and we are very excited to have Dr. Alejandra De Mendoza and Dr. Judy Wang as our guest speakers. Just so everybody knows, I just have a few housekeeping items, and just so that everybody knows, you will be muted during the presentation. You may share your questions by typing them into our chat box, and we will be happy to address all of your questions at the end of our presentation. Very important for us, we will be emailing a survey to all the participants as well as our guest speakers. So we would love to hear back from you. Our feedback is really helpful so that we can take all of your opinions into consideration as we come up with new topics and improve our presentations. Next slide, please. And for all of you who are interested in our topics, we do our presentation every fourth Tuesday of every month. And we invite everybody to be part of our community by following our link and visiting our GUTS in the community website. All the links will be shared on our chatbot, so you're welcome to grab them from there. And we will appreciate your support by following us on Facebook at GUTS Community. And as part of our housekeeping items, I just want everybody to know that we are recording this presentation, and it will be shared on our YouTube channel as well as our other social media outlets. And I would love to introduce our moderator today. But before that, we just want to make sure that there's a quick disclosure that we just shared really quickly. And so I just want to introduce our presenter and moderator today, who's Florencia Gonzalez. And Ms. Gonzalez is a co-director of the Inclusion of Diversity Population Core under the GUTS team, and she has also served as a community liaison for the Center Community Engagement Core. She specializes on leading efforts to establish community academic partnership for inclusion and underrepresented groups in health research. She also supports investigators in the implementation of community and patient-engaged best practices. She has prior experience managing clinical trials and overseeing disparity health research within community settings. Additionally, she has a history of grassroots field experience conducting case management with immigrant populations and managing public health projects in cross-cultural settings such as Sub-Saharan Africa and Honduras. And thank you, Florencia, again for joining us. And with that, I'll let you take it from here.
Thank you. Good evening, everyone. It is my pleasure to serve as moderator this evening. Please leave any questions that you may have in the chat box. You will have the opportunity to audibly ask questions at the end of the presentation. So
I'm sorry, can I interrupt for 1 second? I'm sorry, Florencia, can you speak into the microphone more?
Sure.
It is a little.
This new computer, I'm having issues with that. I apologize. Is that better?
Much better. Thank you.
Okay. Our theme today falls in line with the National Breast Cancer Awareness Month, with particular focus on genetic counseling and testing for hereditary breast and ovarian cancers, as will be presented by Dr. Hurtado de Mendoza, and breast cancer survivorship and rehabilitation, which will be discussed later by Dr. Wang. What makes our presentation today so special is not only the work that Dr. Hurtado de Mendoza and Dr. Wang are doing in addressing health disparities by including African Americans, Hispanics, and Asian women in health research, but also the importance they place on understanding cultural practices, traditions, and influences that can impact a woman's attitude and decisions to seek cancer preventive or cancer care services. Through their research, they are opening the doors to those who have not been included in research in the past. They are listening to the stories and voices of their study participants and seeking to understand how to best adapt cancer genetic counseling, and cancer survivorship services to meet the needs of diverse women. It is thanks to researchers like Drs. Wang and Alejandra De Mendoza that we are making strides in addressing health disparities and moving health equity forward. Next slide, please. So before our presentations today, we would like to dedicate a few moments to recognize the importance of Henrietta Lacks's cells, otherwise known as the HeLa cells, in cancer research and the many other types of human research where they have been used. Mrs. Lacks was a 31-year-old African-American mother of 5 who sought treatment at Johns Hopkins Hospital in the early 1950s for cervical cancer. Unfortunately, treatment was unsuccessful and Mrs. Lacks passed away in 1951. Next slide, please. In the 1950s, researchers collected cells from patients with cervical cancer who were treated at Johns Hopkins Hospital, but cells from patient samples quickly died. It was discovered, though, that Mrs. Lacks' cell multiplied. Her cells have been used in research due to their unique ability to continuously grow and divide in the laboratory. Her cells have contributed to research on the effects of zero gravity in outer space, development of polio vaccine, the study of leukemia, AIDS virus, and cancer. Our understanding of breast cancer is advancing because of our knowledge of cancer genetics, and Mrs. Lack's cells have continued to inform cancer genetics, leading to improved ways of diagnosing and treating breast cancer. However, in the 1950s, when her cells were being distributed among researchers, there were no established practices for informing or obtaining consent from patients when retrieving cell or tissue samples for research purposes, nor were there any regulations on the use of patient cells in research. As a result, Mrs. Lacks was never asked if her cells could be used in research. Next slide. What happened to Henrietta Lacks in 1951 when the doctors took her tissue for research without her consent would not happen today. Groundbreaking cases like the one of Henrietta Lacks have brought to light the importance of study participant-informed consent. Today, if researchers want to take tissue or draw blood or test new treatment methods, essentially conduct any type of research, federal laws requires informed consent from every study participant. A consent includes information such as the study's objectives, procedures, risks, benefits, and privacy protection. There are also other policies and procedures and offices in place to protect research participants' rights, confidentiality, and safety, such as the Institutional Review Board, Office of Human Protections at Research Centers, and others as listed in this slide. Next slide. While Mrs. Lacks did not voluntarily contribute the tissue that was used to create the HeLa cell line, the misuse of her cells demonstrates the fact that medical advances cannot solely be credited to the scientists who do the research. Keeping this acknowledgement at the forefront continues to change how research is conducted. For instance, we encourage researchers to use the term participant or volunteers rather than subject to recognize the value of their contribution. Research cannot be done without study volunteers. We show respect for study participants when we keep them informed about the outcomes of the research they participated in. Community and patient engagement in research is another way to recognize that non-scientists also make valuable contributions to research in many ways. Now communities and patients are involved in developing some of the ideas for research based on their lived experiences. If you would like to learn more about Henrietta Lacks, please visit these links, which will also be posted in the chat box. So now, I would like to introduce our first speaker, Alejandra De Mendoza. And I need to maximize the slide so I can see. Dr. De Mendoza is an assistant professor at the Cancer Prevention and Cancer Program at Georgetown Lombardi Comprehensive Cancer Center. She is a bilingual social psychologist with an interdisciplinary training in anthropology and communication, culture, and technology. She aims to combine interdisciplinary approaches in social psychology, behavioral science, and communication to develop and evaluate interventions that address stark disparities in the uptake of genetic risk assessment in high-risk underserved groups. Her research focuses on traditional genomics with underserved populations. Dr. Dado, please, you can take the podium, the virtual podium.
Thank you so much for the introduction, and it is my pleasure to be here to share the research that we have been conducted in partnership with community-based organizations. As Florencia was mentioning, there has been a low participation of Black, Asian, and Latinx communities in clinical trials. Recent studies have shown that only 31% of trials report race and ethnicity, and that the participation of minorities in the past 14 years has even been slower compared to historical data. You can see it in this chart, how most of the research participants are non-Hispanic whites with very low representation of African-American, Hispanic, and Asian populations. And it is really important for minorities to participate in research and clinical trials to make sure that advances in science can be beneficial to everyone and to reduce disparities. And today I'm going to be presenting two studies in which we collaborated with community organizations, and we capture all the community voices in order to develop culturally targeted interventions to reduce disparities among Latina women around genetic counseling and testing participation. If you can go to the next slide. So today we're going to be talking about screening for hereditary breast and ovarian cancer, which is a topic that is less known. And we know that approximately 5 to 10% of all breast cancers are hereditary. BRCA1 and 2 are the best known mutations, but there have been other mutations that increase the risk of breast and ovarian cancers, as well as other cancers like pancreatic and prostate. So there is national guidelines that recommend referral to genetic counseling and testing for individuals who are at risk. This entails going to a genetic counselor who is a specialist in genetics, in which they evaluate personal history of cancer, family history, talk about testing, potential results, risk management strategies. Then the individuals decide whether they want to do or not genetic testing, which is a blood or saliva test, send the results to a lab, and then the results come back in around 3 weeks, and then you meet again the genetic counselor to discuss about what the results mean, what it entails, what is the impact, and what are the potential risk management strategies. So you can imagine that having this information can be life-saving, because there are risk prevention, risk management decisions to make that can greatly reduce the risk of cancer. However, minorities have had a very low participation in genetic counseling and testing when compared to non-Hispanic whites. You can go please to the next slide. There are many barriers to participate in genetic counseling and testing for minorities, and those include healthcare system barriers such as high cost, insurance, suboptimal referrals, or doctors not discussing with minorities as much as they do with non-Hispanic whites about genetic counseling and testing. There's been also other psychosocial barriers like having low health literacy, low awareness, low knowledge, stigma around cancer, limited communication among family members, medical mistrust, fatalism. But you can see here to the right in this bar chart, this was a study conducted, a survey conducted 3 times over a decade. And you can see that the levels of awareness from Blacks and Hispanics is lower compared to non-Hispanic whites, and that difference doesn't really change throughout this time period. You can go to the next slide. So with this in mind, in our team, we decided to develop an intervention that was culturally targeted for Latinas, to increase the level of awareness, knowledge, and use of genetic counseling and testing. And we did that in collaboration with our community partners, which were Nueva Vida, Capital Breast Cancer Center, and we also engaged the National Conservatory of Dramatic Arts, since the goal was to develop a video that was telenovela style so that it could resonate with the study participants. You can go to the next slide. Thank you. We did a very extensive formative work because it's very important to know what people know about the topic, what are their needs, and what are their suggestions before you actually make an intervention. So we interviewed providers, 20 providers who were mainly genetic counselors, but also patient navigators, psychologists, geneticists. And we asked them about what would be the key messages that we need to convey in relation to counseling and testing, what were their experiences providing services to Latinas, and their perceived barriers and facilitators for them to use the services. We also asked them about suggestions for making the video. You can go to the next slide. We also interviewed 20 at-risk Latina women, and those included women with and without cancer, and they all met guidelines to have been referred to counseling and testing, but you can see to the right in the bar chart how a very few of these women had actually received genetic counseling. 70% of those who had cancer had received testing, but you can see that they received testing without counseling. So they missed really important information to understand the test results. We also asked them about what was their awareness about hereditary cancer, knowledge, what were the barriers, facilitators, and also what were their suggestions on how to make the video. You can go to the next slide. We found that the main motivator for women to participate in counseling and testing was not only obtaining information for themselves, for risk reduction, for treatment, but it was mostly to help family members, because this information is not only relevant for themselves, but also for their relatives. Some of the barriers, as we already saw, included very low knowledge and very low awareness about the services, especially some were aware about testing, but really none had ever heard about what was genetic counseling. In addition to fears about cost and insurance and limited communication, we also found some knowledge gaps. For example, women had a general notion about hereditary, but they didn't know that age at diagnosis was one of the main risk factors. They also thought that the genetic testing could be repeated and you would obtain a different result, or that a positive genetic testing result would mean that you have cancer. So those were some misconceptions that we found. Another one was that women thought that the pap smear, which is a screening test for cervical cancer, they thought that it was also a screening test for ovarian cancer. And unfortunately, there's not effective ovarian cancer test. So that's why it's so important to participate in counseling and testing. The other thing we found was that the word mutation, that is a very important word used in the field, was very unfamiliar, and women interpreted it as mutilation because it's a similar word in Spanish, like similar to English, or also they interpreted it as metastasis or mastectomy. And they also thought that it was only passed through the mother's side. So all this information was very helpful for us in informing how to develop the video and what words to use and not to use when we did the video. If you can go to the next screen. Thank you. So we use all this information that we learned from the providers, from the patients. We contacted the National Conservatory of Dramatic Arts because we wanted to make a telenovela style of intervention that was engaging. So they were the one helping us to develop the script and also to filming the video. And we administered the video with 40 participants. So they answered some surveys, then they watched the video, and then they answered surveys again, and then we refer them to genetic counseling and testing. You can see this is the characteristics of the sample. Women in the sample had low education, low income. They were mostly uninsured, mostly unaffected, so they were not diagnosed with cancer. They had very low awareness about genetic counseling. You can see in the bar chart to the right how most women had heard almost nothing or relatively little about genetic counseling, even though they should have been referred to counseling and testing. And you can see also below in the genetic testing referrals how very few had been referred to genetic testing, even though they met guidelines. You can go to the next screen, please. We found very promising findings in that after watching the video, women significantly increased the knowledge, intentions to participate in counseling, increasing favorable attitudes, positive emotions, they reduced ambivalence. We referred all of them to free genetic counseling, and 60% attended counseling, and from those, 82% proceeded with testing. You can go to the next slide. In terms of acceptability, we found a very high acceptability. You can see here in the bar chart to the left how among a scale from 1 to 10, most women rated the video from 9.5 to 10 in terms of their general satisfaction, how they found it interesting, how much they liked it, enjoyed it. You can see here in this code, participants saying, thank you, this video has helped me understand it, take the strength from that we can move forward with the obstacles and sickness. So the video was empowering and women felt identified with the video characters. They also suggested many ways of disseminating the video in the future, including social media, YouTube. You can go to the next slide. So unfortunately, this was a very small pilot with 40 women, but now we obtain a larger grant in which we are comparing the video with a fact sheet, and we are comparing it in a larger sample of 300 women in different sites, and we also expanded our community organization. So we're very excited to go for the next step of this telenovela video. If you can go to the prior one. Okay, so now I'm going to also share another intervention that our team developed. This was an adaptation of an already existing intervention that was a telephone genetic counseling intervention. And the idea was to do a cultural adaptations to also to enhance the use of genetic counseling and testing for Latina women. You can see here all our partners with Nueva Vida, Capital Breast Care Center. And yeah, you can go to the next slide. Thank you. So the rationale for this intervention was that there was a study showing that telephone genetic counseling was equally effective as in-person counseling. In the past, most of the sessions were in person, but they wanted to see whether doing counseling by phone was equally effective. This was a study conducted with almost 700 women, and they showed that telephone genetic counseling was safe, it was acceptable, it was effective, and it also reduced the cost. But the sample was mostly high-income, non-Hispanic white women who had self-referred to counseling. So our goal in the study was to see whether telephone counseling was an alternative strategy for Latina women, because it could reduce the cost, the logistic barriers like transportation, and also the language barriers. There's very few genetic counselors in the US who speak Spanish or who speak a language other than English. So if you do genetic counseling by phone, you're giving access to these very few Spanish-speaking genetic counselors. You can go to the next slide, please. So part of the adaptation entailed adapting some visual aids. When genetic counseling happens in person, the counselor often has a booklet with images that help them explain some of the concepts. So in the telephone counseling intervention, those booklets are mailed. However, you can see to the left in the original intervention, there were some visual aids that were hard to understand. If you think about, if you don't have a background in genetics, it's hard to understand that this is a family tree and that what is a square, what is a circle. So what we did was we hired a Colombian artist to create illustrations that could be targeted to our community. And that would allow us to have control over what we wanted to communicate. So you can see to the left, that is the adaptation that we made, in that we were able to do drawings and to present the information in a way that was easier to understand. You can go to the next slide. We also replaced complex genetic information with more basic definitions of the genes and heredity. You can see to the left, you have the original booklet that has the information with the chromosomes, genes, inheritance, and how we adapted it to present definitions about genes, also to stress like inheritance is like flipping a coin, because we had learned from our interviews that some women could feel guilty if they thought that they were passing a mutation. And we also use analogies like the flan recipe to explain the concept of mutations. If you can go to the next slide, please. We randomized this study. We were comparing telephone genetic counseling compared to enhanced usual care. And we also had promising findings in that 9 out of the 10 participants in the telephone genetic counseling arm actually participated in counseling, compared to only 4 out of the 11 participants who were in the enhanced usual care arm. So again, we had promising findings. This was a very small study, and we're hoping to do a larger study with this intervention. But this was just to show a few examples of the culturally targeted interventions that we have developed in partnership with community organizations, and also doing a very extensive formative work to understand the needs of the community. Thank you so much.
Thank you, Alejandra. That was a wonderful presentation, and really love your examples and your explanation of the data. Some of the data seemed quite detailed and scientific, but the way you explained it really, helped us make sense of it. Okay, so now we'd like to welcome Dr. Judy Wang. She is a tenured associate professor of oncology and a member of the Cancer Prevention and Cancer Control Program, which is part of the Lombardi Comprehensive Cancer Center at Georgetown University. That's a mouthful. Dr. Wang's research area focuses on culture, psychology, and behavioral medicine. She has received research awards from nonprofit foundations and National Cancer Institute to investigate the impact of culture on cancer screening and survivorship experiences among Asian Americans. Welcome, Dr. Wang. We'll hand the baton over to you. You might be on mute.
You're muted.
Okay.
Yep.
So, yeah.
We can hear
Can
you.
you hear me? Did you hear
Yes.
me? Okay. Thanks, Ms. Gonzalez, for this nice introduction. So this presentation will focus on women who were diagnosed with breast cancer and their quality of life after completing their treatment. So that's we talking about the cancer survivorship. So as you have known, breast cancer is the most common cancer for many women from different cultural backgrounds. While culturally competent care has been emphasized, research is examining that cultural influence on women's adaptation to cancer diagnosis is still limited. So some articles reveal that cancer patients from different cultural groups have different attitude and behavior. So I try to give some examples here. You can find the results from interviewing multi-ethnic women show that Latina and Asian women were more reluctant to obtain the cancer screening or having clinicians touch their private area, such as breast and or cervical exams, as their cultures emphasize modesty. And this study also found that African American cultures values family and spiritual supports. So breast cancer diagnosis might increase African American women's fear for other family members well-being and feelings of disgrace on their families. On the other hand, research also found that their spiritual connections with God strengthen their coping with breast cancer. However, their experience with racism and makes their healthcare utilizations less optimal. And such cultural influence is real and common in clinical practice too. So a physician presented a case that a hormones patient did not respond to her questions, but kept looking one of the males in the family. They came together to see the physician. So this is because in hormones culture, the eldest males in the family make decisions. So how to incorporate family members' opinion into the treatment decision making is also important for some patients from different cultural backgrounds. So could we go to the next slide? So in the following, I will share my research data presenting the racial differences in breast cancer survivorship between Chinese American and non-Hispanic white women, or I call the Caucasians hereafter. The two, we do the compare the Caucasian and Chinese American because they have a very distinct cultural beliefs and norms. This table shows that they are different philosophies. Chinese culture emphasizes conformity to authorities who have professional knowledge and skills like physicians, whereas American culture emphasizes individual interests and self-autonomy. So we found that Chinese breast cancer survivors were more like obedience, even they see the physicians did not answer their questions or were rushed during the encounters. Also, Chinese women put families like interests before their own interests, so that they were less likely to disclose their emotional distress to avoid burdening their families. Whereas Caucasian women mentioned that they would like to express their emotion to their family members and close ones to share their emotion together and to support each other. So there are the cultural differences. Also, like we are aware of the immigration, like stress. For the majority of Chinese Americans are immigrants. So therefore, many Chinese survivors have limited English ability. And so that makes them harder to find a job. And they were more likely to worry about losing their jobs and health insurance. So, and also immigrant Chinese survivors were less able to afford cancer care costs and no health care information in their neighborhoods based on their reports. So also like there is a cultural difference is representing in their lifestyle. So we can see the next slide to see the lifestyle differences. So this slide shows that 80% of Caucasian breast cancer survivors adhere to the recommended physical activity level for cancer survivors. However, you can see the right spot, the low acculturated Chinese, among them, only 62% reported they adhere to the recommended physical activities. When we say the low acculturated Chinese, that means they have like a lower English ability in speaking, reading, writing, and listening. And compared to higher acculturated Chinese, they have a better English proficiency and also live in the US over 5 years. So they were behaviorally more assimilated to the American culture. You can see the adherence to the recommended physical activity level is more similar to Caucasian breast cancer survivors. Let's go to the next slide. So this slide, the other one, the previous one. Yeah, so this slide, you can see there were no differences across the next one, sorry. Yeah, you can see the differences across the three groups, like Caucasians, higher acculturated, and lower acculturated Chinese American survivors. No differences in their working and moderate level of physical activities. The differences is in vigorous physical activity. You can see that 48% of Caucasian breast cancer survivors reported engaged in the vigorous activities, and then 45% among like a higher acculturated Chinese American breast cancer survivor, and only like 14% of low acculturated Chinese breast cancer survivor reported engaged in the vigorous activity. This may be cultural differences because the American culture values like a sports achievement and may engage more in strenuous like physical activities or vigorous activities compared to Asian culture. For those lower acculturated Chinese American, they do not value that much about the sports achievement or engage in vigorous activities. So this can be an implication of a cultural influence on breast cancer survivorship, like a coping through the physical activity. Next. And we can also see like Chinese American have a different dietary practice, particularly soy foods are commonly consumed in Asians like everyday meals, such as like soy milk and tofu related products. And my study found that about like 50%, you can see the green bars, yeah, on the highest level, like more than 24 grams every day. More than about 50% of Chinese American breast cancer survivors consumed a higher level of soy foods. In contrast, only 20% of Caucasians reported a similar level of soy consumption. You can see on the left, like blue bars, there are 42% of Caucasian survivors have no intake of soy products. So that's the cultural differences influencing their dietary practice. Next one. I didn't show the slide here, but we found that soy food intake influence like breast cancer survivors, like menopause symptoms. So we found there's a higher level soy food intake also have a less like symptom, less number of like a menopause symptom reported. Okay, for this slide, we show another like a social cultural differences between like a Chinese American and Caucasian breast cancer survivors who have a different stress and coping style. In this table, you can see like a low acculturated Chinese survivor had the poorest like communication quality with physician, and also perceive less control like over breast cancer. So their score lower in communication, in perceived control. Also, they were less likely to use like engagement coping in terms of like they less likely to use like a problem solving strategy. They were less likely to use the planning strategy compared to Caucasian breast cancer survivor and highly acculturated Chinese breast cancer survivor. They also were less likely to have like a social economic well-being. They had they reported less like social economic like support. They reported less health care information, and they also had less like a social support and smaller like a social network compared to Caucasians and highly acculturated Chinese American survivors. Yes. Next one. So you can see as a result, more Chinese breast cancer survivors, 52% of them reported that they had experienced like a fatigue symptoms, compared to like only 35% of like a Caucasians reported like a fatigue symptoms. Next. So therefore, we look for like the physical functioning, because fatigue is a key indicator of physical functioning. You can see the graph shows that low acculturated Chinese survivor had a poorer like a physical functioning. They are 3 points less lower than the Caucasians, and also like lower than the highly acculturated Chinese American breast cancer survivors. And those are 3 points lower is clinically meaningful differences. And so you can see they had like a poorer like a physical functioning. So we are thinking about how we can help these like a low acculturated Chinese breast cancer survivor. Can we go next? We look for like a culturally appropriate intervention to help Chinese breast cancer survivors manage their fatigue and promote their physical functioning. Sponsored by the National Cancer Institute, like R21 research grant, we develop and test a self-administered acupressure intervention. And acupressure is derived in the same theory of acupuncture. And according to the Chinese medicine, we found that the acupuncture and acupressure all try to stimulate like acupoints near the acupoints located near our organs or vessels or tissues in the body. and to stimulate. When you stimulate the acupoint, they send the signals to our brains, and so stimulate our brains to make the brain functions to release the hormones. Those hormones can modulate our stress, pain, energy, sleep, and anti-inflammatory biomarkers. So we then enroll 89 Chinese breast cancer survivors who reported mild or severe fatigue, and randomize them to the acupressure intervention group and compare their symptoms and functional outcomes after 6 weeks intervention to the usual care group. And usual care groups means that they are the survivors doing their routine care without additional materials or programs provided. Yeah, so you can see the 3 acupoints that we mentioned here. So is one on the hands, and there's a one near the ankles, and there's another one acupoint just under the knees. Yeah, so survivors learn how to perform the acupressure by watching a video. You can see a picture like a physician and the patient here. By watching a video where a Chinese medicine doctor instruct patients how to use their fingers and thumbs to locate and put the appropriate amount of pressure to on those 3 acupoints. And patients need to massage each acupoint for at least 1 minute every day. So each acupoint is parallel on the other side of the body. So survivors can spend 6 minutes per day, 3 points on 2 sides of the body. So for 6 weeks, and they record their performance on a daily log every week. So we have the patients practice the 3 acupoint on both sides of the body for 6 weeks, and each day they only spend 6 minutes. And then we have them to record their practice on a daily log, and we send the RAs who trained by the acupuncturist to check with them in person to see if the breast cancer survivor performed accurately. Next slide. Yeah, so you can see this is our preliminary findings, and you can see that in the acupressure group, fatigue breast cancer survivors, they increase their physical functioning. So you see the positive 3.3 3 points. That means after they practice the acupressure intervention, we found the changes between the baseline before the practicing the acupressure, and has a 3-point increase after they practice for 6 weeks. So that shows the acupressure intervention increased their physical functioning by 3 points. And they reduce their depression by 3 points too. So you can see the negative sign, that 3.1 means that the acupressure group has a 3-point reduction of the depression. They have a reduction in the other function and symptoms anxiety, and also fatigue, and that's 11.8 points, and then sleep disturbance, and also pain interference, and increase the cognitive functions. So you can see in the acupressure groups, they all have a significant improvement in their functional status and symptoms. Compared to the usual care groups, we only see the significant improvement in the reduction of fatigue. Remember that they do the routine care, but they still can do the exercise regularly as they for their preference, and looking for the other intervention as their preference too. Yeah, so we can see the next slides. And so giving the beneficial effect of next one. Yeah, giving the beneficial effect of self-acupressure in Chinese breast cancer survivor, we propose, and we also found there's another clinical trial shows that its beneficial effects on Caucasian breast cancer survivor. And so we were thinking about if this intervention can be suitable for to practice among the Black and Latino breast cancer survivor where many of them experience fatigue, depressive like symptoms, and poor like functional status. So we recently received a National Cancer Institute's community research network at the Wake Forest University's pilot funds. So we have a community member joining us, Nayovida, and also the Selma D. Jones, breast cancer funds to support our pilot testing of this occupational intervention in Black and Latino breast cancer survivors. We will also conduct this pilot pilot study. We will randomize those Black and the Latino breast cancer survivor into one occupational intervention, and also enhance the usual care arms. We will have them to practice the same 3 acupoints too, but extend them to from the 6 weeks to 8 weeks, and then we will have them record their performance on the daily logs. And in this pilot trial, we implement one component to have in addition to the in-personal training, we also have 3 virtual training by checking in with them every 2 weeks. Yeah. So we haven't really started this pilot trial yet. We are in the planning stage, and hopefully we can show the research result in another probably 6 months later. So hopefully we can share with you more information next. So I would like to conclude the research presentation by giving you some take-home messages. Research has demonstrated attitudinal and behavioral differences in reduction of cancer risk and adaptation to breast cancer diagnosis among minority and immigrant populations. And the input and feedback from patients and community members on the cultural relevance of intervention programs and research materials contribute to the success of research studies. So research tested evidence is scientifically rigorous in order to assure a safe and beneficial practice in the clinical and community settings. So we greatly appreciate our participants, those who contribute their opinion and feedback, and also our collaborative communities in raising breast cancer awareness through the research and community events. Thank you so much all for contributing to our success in the research work. Thank you.
Thank you, Dr. Wang. That was a fantastic presentation, and it's your work is so important and it's so relevant. I mean, there's potentially a lot of the research, health research is not, it's not intended to have a direct benefit to patients. It's for an understanding of for future generations. However, your research really is impacting patients directly. So thank you both, Alejandra and Judy, for being with us here this evening and sharing your information about your studies. So we'd like to open the floor for questions that anyone may have. I think that in lieu of Wendy had said, please type any questions here, but we have such a small group. It'd be great to include, to have a discussion. Please feel free to ask any questions you may have. You could do it in the chat, or you can unmute yourself and share your questions that way.
So I think we're allowed to ask questions too, right?
So we have okay. I'm sorry. Go ahead. Go ahead, Wendy.
I'm sorry. There is a question from somebody else. I'm gonna go ahead and let them go first.
It's from Don. It's to Dr. Hurtado. How do you plan on disseminating your findings to the community? I had the same question.
Thank you. This is an excellent question, and we have to make sure that researchers not only publish research for scientific audiences, because as researchers, a lot of them only publish manuscripts or go to scientific presentations without really giving back the knowledge to the community. And I think it is key that we give back the information and the findings to the community. So in our team, we have used different ways of disseminating the information. For the video, we did an event at a community setting in which we played the video, we showcased the video, and we invited not only community members, but also the participants who had given us suggestions about how to make the video in the formative phase. So then they could come and watch the video. We could thank them for everything they contributed. And I think it was a great opportunity to see what participation, what was the product of the participation, and how without their participation we would never have been able to develop the video. So that was one of the ways we disseminated information. We also developed newsletters using infographics so that we can convey the information in a way that is easier to understand. And we disseminated through our community-based organizations, and they also share within their listservs or like in Facebook. And we also participate in this type of meetings with Nueva Vida. We are also very active with the Thelma D. Jones Breast Cancer Fund, and that has been a great way for us to disseminate the findings from the studies that we have been conducted together. With Ms. Jones, we have also done publications at local newspapers. So those have been some of the ways that we have made sure that we're providing findings back to the community.
And Dr. Wang, a similar question for you. That it sounds like the self-acupuncture is such a beneficial, non-invasive type of treatment, or complementary and alternative treatment for women with cancer. What are ways that you plan to get the word out as to the effectiveness? At least you seem to be finding some effectiveness in this form of treatment. How do you plan to get the word out?
So we think about like several things from the clinical point, and also like which way we can save like a patient's time. So then I found out this like acupressure is kind of treating as an alternative complementary medicine, and also they now call like integrative care. So maybe this is a way we think we can connect the traditional like conventional medicine, and still has another way that we can be an adjuvant kind of support. And so then we tested this out, and we found, oh, interesting, this like a kind of approach not only reduce fatigue, but also helping patients to manage their sleep. And when they sleep better, and they feel like kind of more energetic. And they also, several patients, we also test this in for the GI patients who are under chemotherapy. We found very similar like results, but I didn't share that with you here. And this is focused on the breast cancer awareness. Yeah, so we think about maybe there's a joint points, not only focus on the pharmacological treatment, but also have some like a non-pharmacological treatment that can integrate it together to help patients to really with something they can do on their own. Yeah. So this is the idea. And we're so glad that our community members here, like Ms. Jones and also Niovidas, who are very willing to support us together. Yeah.
So Ms. Jones, Thelma Jones, she runs a Breast Cancer Foundation in Nueva Vida that Dr. Hurtado and Dr. Wang have been referring to, are community organizations who have partnered with researchers, not only for these studies, but other studies. And we do actually have Ms. Jones here. So glad you could join. So thank you so much, both of you, Dr. De Mendoza and Dr. Wang, for your presentations again. This is really wonderful to see that research, as we know, in clinical trials, treatment, taking up medical treatment is not the only way research is done, and that there are other ways other types of research like the ones you are doing, and the fact that including diverse groups in your research. So thank you for all that you're doing. So we will move on now and just share a few slides.
I think Ms. Jones was, I think someone else had a question that I wanted to. Does someone have a question?
Yes, Wendy, Dr. Wang, sorry about that. Thanks, Dawn. Dr. Wang, I find the acupuncture study so interesting. Were other factors that could have influenced the results controlled, and how about placebo effect?
Yeah, so that's a really great question. And we have a very small samples, like we only have like 89 in total, 51 in the acupressure group, and then 50 in the acupressure group, and 21 in the usual care at the end of like a 6-week intervention. So we have like some attrition, but the attrition usually is because like after they know they randomize to the usual care group, they either don't want to participate, we couldn't follow up with them, or some after like we deliver the intervention, they learn from the video and they receive the in person like a training, they knew how to do it. So when we follow up with them, we couldn't really reach them further. Yeah, so that probably the two main reasons that we had the attrition. But we found like when we analyzed the study, we're thinking about is that the acupressure intervention effects because like they also do the physical activity and using other practice, and is the usual care, maybe because after they know they randomize, then they do better from like doing more exercise and doing more other things, so they kind of have some like different performance. But then we found that like we do find like a usual care group has a higher level of physical activity compared to acupressure group. And then we found that when we do the correlation, we found the correlation in the correlation between the physical activity and the fatigue reduction is significant in the usual care group, but there is no significant correlation in the acupressure group.
Mm-hmm.
Yeah, so we wouldn't see this is like a placebo effect, like as people assume that maybe it's for other factor. We see this is consistent. The acupressure effect is more consistent in the acupressure group when we try to account it for the physical activity. Yeah.
Thank you, Dr. Wang. We are at the top of the hour, and I just want to point out that Ms. Jones has included the correct name for her organization, the Thelma D. Jones Breast Cancer Fund, and she has included the website. It is 8 o'clock. We do have one question. I'm not sure if we, could take, well, we could, why not? Let's take the question. Dr. Hurtado, are you planning on developing videos in other racial and ethnic groups?
Yes, that's an excellent question, and it has a short answer, which is yes. So in collaboration with Dr. Shepard, she has a grant that was funded by the NCI, an R21 grant, in which we developed a similar video, telenovela style video for African-American women at risk of hereditary breast and ovarian cancer. That video has already been developed. It was developed through COVID. So imagine like all the limitations. So we had to do it like through Zoom. So it's going to be interesting. And now we are in the process of testing the video. So hopefully next time we come, we will be able to share findings about that study as well.
Well, thank you everybody for joining this evening. And we do have events, as mentioned by Wendy, we do have these events. I believe, Wendy, could you share again when our next event will be?
Absolutely. Well, first of all, as you guys have seen the slides, we do have a participant advisory board, and we are putting the link in a chat if you're interested in learning more about it. We are currently recruiting, so we would love to have you join us if this is something you're interested in. And lastly, just super quickly, we just want to thank the team for all their hard work, and as of course, Dr. Alejandra Hurtado and Dr. Wang for participating. And then if you have any questions, you can send it over in that link. And again, another reminder, we will be sending that post survey, which is extremely helpful for us. So please be in the lookout for that email and respond at your earliest. And again, like, thanks everyone. We share a bunch of links. And then our next event is on November the 23rd, and we're really excited to present on National Alzheimer's Disease Awareness. And I really hope that everybody can join us. We will be sharing advertisements through our Facebook page and also via email. So again, thanks everyone. Thanks, Ms. Florencia. This has been an amazing conversation, and we look forward to having you next time.
And I would like to add one more thing. These events are recorded, and so we will send around the notice of recording so you could disseminate it amongst your community as well.
All right. Thank you so much, everyone. You have a great evening.
Thank you.
Thank you.